whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. Today's guest is a family physician and a fierce advocate for doctors and the healthcare system. She's held numerous roles within administration and oversight organizations at both the provincial and national levels, and she is a change maker and founding team member for the highly acclaimed Pathways BC platform. Today, it's an honor to be speaking with the current sitting president of the Canadian Medical Association, Dr. Kathleen Ross. Thank you for joining me today.
Oh, I'm really happy to be here, Jordan.
So, following the CMA's cross-country consultations with the public and the medical profession, today we're talking about the balance of public and private healthcare in Canada. Now, you were just saying you went through how many different meetings and sort of town halls on this to gather information?
21 engagement events across the country and over 10,000 people engaged in those.
Holy smokes. And this was over what kind of a time frame?
Oh, we started in September last year and finished in March.
Okay, it was quite the information gathering process. So I guess for context, how do you define private healthcare? You know, private healthcare is in Canada. There's sort of this balance already. What do you consider to be private healthcare?
So it's actually a really great starting question and one that we worked really hard to try and define when we were leading these engagement sessions. The answer is not as simple as you might think. For most Canadians, we think about services when we pay out a pocket as that's private care. But those that we don't, obviously, we view those as public. But when we factor in how we deliver healthcare, the definition gets really much more complicated. Some services might be publicly funded, like privately delivered. A great example of that is the government pays me to privately deliver services in my family practice offices. So that that definition isn't exactly clear. We have publicly funded and publicly delivered in the hospitals in many places, and then of course privately funded and privately delivered care, like a plastic surgeon's operating suite. Those are things that people understand, but there's so much overlap between the two that it's a challenge. So when we set the stage for these discussions, I kind of started from a position of what are the provisions inside Canada's Health Act as it sits right now, and those key priorities we wanted to keep in mind while we were talking about what we mean by a public healthcare system. And the first is that it be universal, so to make sure that it's provided to everybody in every province and territory. That comprehensiveness, so that all medically necessary services are provided by hospitals, physicians, and even dentists are included in that. We can come back to the definition of what we mean by medically necessary a little bit later. And certainly accessible is in those tenets. And that means that when you need something, it's unimpeded by discrimination of any kind. And really that includes our ability to pay for services. And then portability, so that if you travel from one part of Canada to another, you're able to get services and publicly administered by a not-for-profit government or health authority agency. So those are the basic principles, and they're kind of aspirational because certainly given our current crisis and our human resource crisis, we're not meeting all of these for everyone living in Canada. And that's really what's driven the rise in discussion about do we need to increase the role of private care? Underlying all of this, and I'll make this point again and again, is that we don't have good data in many areas of our healthcare services in Canada. And we have silos of data between jurisdictions inside of provinces, between provinces, and really a lack of standardization in how we collect data around what we're actually providing to Canadians. So that's a long-winded definition to say it depends.
And why now? I mean, there's been a lot of talk about the healthcare system and the cracks showing, or the cracks have been evidently growing for many years now. Why now? I mean, it seems like obviously you guys are putting a ton of effort into now doing some data gathering and research. And bringing up the discussion around the public-private side of things. What's going on in terms of this year?
So I think the pandemic had something to do with this because we saw an exponentially quick transition to virtual care as a result of the pandemic limiting face-to-face management of symptoms in healthcare. And we saw then the creep of corporations and for-profit healthcare companies coming in to deliver those virtual services that Canadians need. So, as a bit of a background, the CMA does have existing policy with respect to that public-private interface, but it was established in 2007. And obviously, a great deal has changed with regards to our healthcare system since then. And certainly, we review policies on a regular basis, but the need to re-examine this in the light of these new realities. So our healthcare crisis, the rise in virtual care services, the rise in public and private partnerships with the goal to deliver and fill gaps. These are all shifts. And if you think back historically, the CMA did do a similar type of engagement with the public on medical assistance in dying and on legalization of marijuana. So we really undertook this as kind of a time-limited process to understand what the Canadian public knows, where are the gaps, and what's the sense of how we can partner between public and private care. Should we partner between public and private care? And what role is there? You already highlighted a really essential point, and that is that private care already exists in Canada because we have these limitations in what's publicly funded. So we looked at the evidence around that, and approximately 70% of healthcare services are delivered publicly, funded publicly. But in Canada already 30% is paid for privately, whether that's through patients paying out of pocket or through a third-party insurance agency. But we have this balance already. The real question is it meeting the needs, and is this the way that we want to progress?
I mean, it seems to be becoming more and more clear that it is not meeting the needs. Like the wait times are increasing, the wait lists just to find a family physician are getting higher and higher. Those barriers to care continue to grow. Do you think it was driven a lot by the pandemic? You mentioned the virtual care sort of being part of the impetus there. That seems a little bit more of, an extension of that privately delivered, publicly funded model. Or is it something else about the virtual care that's actually pushing this into the conversation?
There really has been, as I said, that long existing mixture of public and private healthcare in Canada. And, the majority of hospitals and physician services are funded, but services like home care and long-term care, prescription drugs, even in community and dental care services, there is already an existing mix of public and private funding sources. And I think a lot of us forget that. Most hospitals are definitely publicly funded, but private for-profit organizations, as I mentioned, such as long-term care homes, are really a mix. And local public health services, those are typically run by the public sector. And as I already mentioned, majority of physician offices like mine are a private, for-profit business, so that I can have a place to live and feed my family.
Do you foresee private healthcare, I guess, becoming more preeminent going forwards? Does that seem like a viable solution to that access to care and all these different flaws in the system?
Well, you already mentioned, and we need to recognize that our current system is not meeting the needs of the population. And, really highlighting those challenges that we all know well: more than 6.5 million Canadians without access to primary care. And of course, the long waits for diagnostic testing, for surgeries and other life-saving treatments. And we see this in the news almost every day. So, last August, leading up to this work, Angus Reid Institute released a survey that said, in the neighborhood of 70% of respondents really thought that the quality of healthcare in Canada had deteriorated in that last 10 to 15 year window. And almost 60%, or just over 60% actually, showed that there was some challenges or chronic difficulties accessing care. So, I mean, we really do see more private funding and more private delivery options now being explored and implemented across the country, and honestly by some governments, alongside this growing number of private companies stepping in and offering for-profit and not-for-profit services like virtual care, diagnostics, and surgical services, and more. So we have to be aware that the prevalence is rising, and have a mature discussion around if that's what we want or not.
Is there any data or analysis of these pockets of private healthcare in Canada and whether or not it was a detriment or a benefit to the system?
So at the CMA, we're undertaking a deeper dive right now. So we've been generating evidence briefs and having a hard look at what exists now, and what's coming into Canada, and what does the evidence say, globally, about the impacts of increasing private for-profit care. And I think that we'll have to see, what that actually shows to help inform our recommendations moving forward. But the majority of physicians, I would tell you, and the majority of people that with lived experience that participated in our surveys really shared very similar hopes and fears around the expansion of private care in Canada. And I think we've kind of divided it into the top 10 hopes and top 10 fears, and as I said, they're not that dissimilar.
Can you share a little bit about what those are? What was sort of that feedback coming from the public and from the medical professionals on that debate?
So certainly from a hopes point of view, that access to care would be equitable, chimed through again and again. And we have to recognize that this discussion of public and private healthcare in Canada really pulls at our values as Canadians. We view ourselves as universal, as equitable, and wanting to take care of everyone that lives in Canada. But that chimed through, and really importantly, most participants hoped that there would be an access for a primary care provider for every Canadian, and that included the expansion of team-based or community-based care. We also heard a lot about hoping for increased health system efficiencies and reduction in wait times. Although we recognize in Canada that we do wait for things, it was a real push to try and reduce that. We heard a lot about appropriately funded healthcare systems that are sustainable, and that means we would want to be more investing in those upstream issues that help to prevent chronic disease and illness. So more health prevention and promotion. Pe- People with lived experience really wanted to have the shared decision making. So they wanted to be empowered to make choices. And that meant they were hoping for better access to their own health data, their own health records, and having a better understanding, of what was covered and what would be expected to not be covered. The final piece that was, well, two final pieces. One was about the need for our publicly funded system to become more comprehensive and expand to a wider range of services. And the three that rose to the top were mental health care services, counseling in particular, pharmacare, so better coverage for drugs, and dental care. And then the final thing we heard loud and clear was the hope that older adults, so our population is aging, we know that it's becoming more complex, but ensuring that older adults had adequate access to safe, quality healthcare, and really a right to age with dignity. So when we look at all of those things, and I left off that many of the respondents, both patients and providers, highlighted the need to really work on and support the mental health and well-being of those of us providing care. So there was a recognition that the system was challenging, and we need to have a little bit more support and appreciation for those that are delivering the services. Then from a fears point of view, not surprising, I don't think, to anyone, but there's a great fear about the diversion of resources. So if we're introducing a private healthcare system, are we going to take away, dollars, human resources? Will there be a mass exodus of healthcare providers to such a system? And a real, as I said, tension arose that people in Canada who could afford private healthcare would actually be able to access that care, and people who didn't have the financial means to do that would suffer, and we'd see that deepening of pre-existing inequities. That was definitely a challenge. And then an interesting quote from one of the participants that I remember was in Halifax around the fear that if we push to a more private healthcare system, that our public system may well become less comprehensive, more narrowed and more restricted, and that we would see a greater drive towards politics in healthcare, and get caught up in the same cycle that we're in again and again of just short-term fixes to be politically expedient and not have that long-term plan of what Canadians need.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, nurses, chiropractors, and all other healthcare professionals can sign up for free, start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across Canada. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with hundreds of new jobs posted every week. www.cherry.health to get connected today. Going through medical school and residency, often Australia was cited as kind of the golden example of switching to a more privatized system and then pointing out that wait times actually got longer. I don't know, do you think that going to the private is going to help? We're looking at some of the data, right? In Canada, we spend above average amount of our GDP on healthcare, but yet we've got a well below amount of physicians per capita, well below in terms of hospital beds per capita. We're still living a decent amount of time, but where does the money that we are spending go? And would having perhaps an influx coming from the private side help rectify some of those shortfalls of just there's not enough providers and not enough hospital space?
So these are all questions that we're trying to explore with our evidence brief, and I'll answer that question with a little tiny bit of a caveat, because we do need to be careful directly comparing systems around the globe, because some of the other OECD nations have very different social safety nets than we do in Canada. Their social services may be different. Their housing may be different. So I think we can't directly compare, but that doesn't mean that we shouldn't shamelessly steal from other jurisdictions when things make sense. But we need to understand them in the Canadian context. So more data is going to be critically important to understanding how does the Canadian system work. The transparency and accountability for where dollars get spent was actually a key proposal in the recent bilateral agreements. In the last year, the federal government has committed $196 billion. That's an unprecedented amount of money into the healthcare system. But tied to that is really the need to understand where are the gaps, what are you doing to address them, and where are the dollars going to address those areas that need attention, and then hopefully building from data on a learning forward system. Not to say, oh, you didn't deliver what you were going to deliver for those dollars, but why didn't the services wind up being delivered? What did you run into in the way of gaps and challenges on the ground that might be different? Underlying all of this, and I want to come back to it again, because there was clear consensus in the groups that we engaged with that people want timely access to care in Canada. And it is really an access to care crisis that we're suffering from right now. But it was super interesting dialogue, because we debated sometimes quite heatedly what we meant by timely access. There isn't a clear definition or consistent definition across the country on what we actually mean. And we don't have good evidence around what is a reasonable wait time. Although an attempt was made, 10 years ago, to have a wait times list of how we expect certain services to be delivered in a certain period of time to so many people. But there's unfortunately that timely access piece that we need to revisit. And then, of course, people want choices. We're used to having choices of every kind in our day-to-day lives. And if the wait time is considered excessive, people want choices. And other jurisdictions in the world, there are systems in place where if you can't access the care you need in a timely way, there are some options for you. So how does that work? What does that work? What is the evidence? I think that we need to really take a step back and understand what the evidence says and how does that apply to the Canadian context. But underlying all of that, strongly emphasizing that promoting timely access shouldn't jeopardize equity. And that and again, we heard strong voices saying that it would be inequitable if people who had financial means could go and access care, and those that can't access care because of financial limitations would be left behind. And I think that the messaging really needs to be that we can improve our access to care by strengthening and building in sustainable investing in our public healthcare system rather than relying on public choices.
I mean, the accessibility thing seems to be just a growing and bigger issue. And then on the other side of the thing, pointing out that the transparency when it comes to the funding and the accountability of where does the money go in terms of facilitating that accessibility, right? It's like, where are the actual bottlenecks in the system? It's probably kind of hard to tell unless we have good data on that, right? Again, we're spending lots of money, but then these endpoints that we look at, now, of course, those are only a few different chosen metrics, but it doesn't look favorable in terms of efficiency overall.
Well, I think that's right on the money. We need to get better at collecting and sharing data. There's a well-known comment I hear from my colleagues around the world, and that is that Canada is the place where all good pilot projects go to die. We're really good at naming the problems. We're really good at tiny little tests of change. We're not the best at implementing those successful changes at scale, and we're not great at sharing our successes from province to province to province. Last year, the CMA undertook a process to really look at what were the healthcare priorities across Canada in our 13 jurisdictions. And the report shared that really they weren't that dissimilar. The approaches were slightly different, but they weren't that dissimilar. So if we know what we're aiming for with regards to publicly funded healthcare in Canada, let's standardize it. Let's be transparent with the public about what's in the bucket, what would be covered and what's reasonable to expect in the way of a wait time, and what are potential options if we're not able to deliver on those services. The question of choice really did rise quite regularly in these discussions. I mean, patients felt that they should have the ability to choose their healthcare provider or their physicians, but we heard very strongly from people with lived experience that their ability to shop around and find ulterior sources in this system of chaos that we have is quite limited. And some had only one choice in their community and others had no choice whatsoever. So I think we need to actually think about that. But I also want to be respectful of physicians' autonomy and their desire to be able to choose how and where we work. Because, we have patients' choice for access to care for not-for-profit or for-profit care. Does that oversee the greater good? Do we want to ensure that we want to make sure that every Canadian has that accessible, timely access that we know they want, and in what way? So choice really can't supersede equity considerations, and those tensions that we have been talking about, that often framed as an either or, but we really do have to understand that these are not at odds and already working in Canada in partnership.
It's a bit jarring for people, right? They're otherwise living in a very abundant society, and then there's this one facet of life that just is annoyingly frustrating, of you just can't get a doctor, and it's just been going on for so long now. It seems like it's coming to that breaking point where something needs to change.
There's no question at all. There's been a lack of foresight with regards to training all healthcare providers, not just physicians, but all healthcare providers across the globe. So we're facing challenges in Canada, but all jurisdictions in the world are actually facing similar challenges. Our population is growing, and the healthcare services that we are able to offer people are actually also growing, and care plans are becoming more complex. Our population is definitely aging, and we're seeing more people living longer with chronic illnesses. So it's a definitely new world. So we're here now. Let's try and deal with what we've got here now. So we cannot assume that we are going to be able to recruit or train our way out of our current healthcare system crisis. If that's the case, then we need to take a step back and have some fairly good, solid discussions about what we need in the way of services in the next 5 years, 10 years, 20 years, and then start to build out the who. So we see lots of push now, active push across the country towards more of a team-based delivery model. And there's good support for that team-based model of care. Patients understand that they may not need to see their family physician for all of their ills at the beginning, that they may be able to see a physiotherapist or a social worker or counselor or a pharmacist as their entry point into their primary care team. But what we heard loud and clear through these engagement processes is it is the who that is delivering that care that matters most. People want to have that longitudinal, long-standing, continuous relationship with care provider or a team of providers that they know they can turn to and rely on in their hour of need. That mattered more than the who. So I talked a little bit about these cylinders of excellence that exist across the country. I used to call them silos, but they really are pockets of hard work that people have done to meet the needs of their communities. And team-based care is showing success and value in meeting the needs. So looking at how we can optimize the scope of practice and enhance the working together piece so that we can ensure that Canadians get what they need here and now today. We are not going to be able to train or recruit enough people to solve the problem, so we're going to have to think outside of the box.
Well, it's interesting that you mentioned, we've got these pockets of excellence, but then we've also got these just pits of despair, and that's where, innovation and pilot projects go to die. I don't know if you can speak at all to like how other countries operate. Are they similar in terms of we've got completely independent healthcare systems on a per province basis? And, maybe again and again, this issue of fragmentation continues to come up in terms of the inefficiency built into the system. Are other countries doing things differently or having more of a central or more of a economies of scale efficiency to their operations?
So I would say, having had a recent look at every jurisdiction around the world, each of them is subtly different, but many are struggling with the same human health resource problem that we have. I think that it could, I'll try and keep it within Canada as good examples, but if we look at examples of what's worked well in Canada, we have massive healthcare deserts, as you've mentioned, areas where people just cannot access care in many forms. Innovation in these areas, I'll use British Columbia as an example, have included things like moving to more of a virtual care delivery system, to look at incorporating a mixture of in-person and virtual care access. We're looking at supporting levels of care providers with real-time virtual supports and enhanced delivery of healthcare services in community. So we may have a nurse that's in your community delivering care, but that nurse is able to access a physician in real time for assistance and improve services. Lots of really great examples. When it comes to funding, again, we have to have a hard look at the social safety nets that exist within Canada and across the world to try and look at comparing them. Nobody's got it right. I'm very excited about the potential for incorporation of health and health tech as we look to improve service delivery. So if we are able to provide those real-time supports through health technology for individuals on the ground, either individual people or caregivers working in certain settings, we should be able to try and address some of these healthcare deserts that we have. But again, grounding back into equitable access. So we need to try and focus on access to care as our main driver, and ensure that we have services that we can deliver, and a little less focus on the who is delivering those services, but what are the services that we need.
And can I ask then, is it all doom and gloom, or are there things where Canada's actually doing pretty good, proportionally speaking?
So you mentioned earlier that we, as Canadians, we still have pretty good health, and we're still, we're still living long lives, and I think that's critically important for us to understand. Although we know our system can be better, our healthcare system in Canada delivers really good quality care. We have excellent care in emergency situations. We have excellent ICU care. We have excellent cancer care. We do pretty well for all of the failings that we have. But what we've seen in the last decade is this widening gap in access. So we know when you get access, you get good quality care. It's getting that access and navigating the complex system of care that we have in Canada that is really limiting our progress. So we do need to start thinking outside the box, how we can streamline services. And I'm very proud of the work we've done in British Columbia with Pathways that you mentioned at the top, because it is a way to help reduce administrative burden, to streamline care in real time in the office, and that's just one of many innovative practices across the country. We're seeing implementation pushing more towards using artificial intelligence for scribing and note taking and tracking access and flow, and making care plans and following up with patients. There's a tremendous potential coming down the line, and we will need to look at partnering with health tech companies if we're going to be implementing more and more digital solutions to address some of the gaps that we have. But we have to have consistent standard recommendations about where we're going, what services we want delivered, in what expected timeline, in what expected geography, before we can actually plan how best to approach the challenges that we face.
I think I'm right there with you, in my biased opinion. I'm hoping we can health tech our way somewhat out of this hole that we've dug, increase that efficiency. Because, yeah, the more we can take advantage of that modern technology, the more we can clean up some of that administrative burden. And again, it's fantastic to see the Canadian Medical Association really putting some fuel on that fire and trying to help grow that. There's a lot of the grant programs going on recently. So I'm really excited for that side of the healthcare system to start blossoming further.
Yeah, it's the sky is kind of the limit, but we have to be careful, because as much as I love the idea of tech coming and helping me in my day-to-day, especially with the administrative burdens and those repetitive low-value tasks that make up so much of the work that we do in primary care, we have to have at the core that there is something special in our human-to-human relationships that no amount of technology is ever going to replace. So keeping a human at the front face has to be a critical piece of what we do moving forward. That's not to say that a human needs to be involved in everything, but we need to understand that there is a human that cares for us and coordinates our care and understands our whole well-being in our lives, if we're going to have the best healthcare system.
So, are there countries out there that we're looking up to, as role models, or perhaps an ideal is a long shot, but are there countries that we're taking advice from in terms of how they're running things, or picking and choosing parts that seem to be doing well?
So I think many systems across the globe have things that we can look to. One of my really aha moments was when I was in Copenhagen last year at a forum on quality care, and it was really eye opening for me to understand their system, that they had a publicly available healthcare system, and folks would look to that first as their method of delivery, but then they had a private side-along system, that if you weren't able to get your needs met in the public system, that there was a private system that you could turn to. But as I said, very different systems, because in that system, the money follows the patient. So in our system in Canada, we have more block or bucket funding. So a health region or jurisdiction is given dollars and said, here's your dollars for the year. Here's the list of services that we need you to deliver inside of that bucket. So a slightly different system. It makes it harder to compare and harder to understand where the role of a private delivery might enhance or detract from that system when they are so vastly different in how they're funded.
It's an interesting way of chopping it up and making the budgets. I can definitely see how that would introduce a little bit of like challenge in managing things.
Yeah, there's so much that we don't know, and I keep coming back to the fact that in Canada we're not great at collecting and sharing our data across the board. So it's a challenge for us to know where to go next.
What about some of the other programs, independent insurance or patients having co-pays? Is there any way that seems like it would be a viable option for Canada to start implementing something like these and on a higher scale, perhaps to start, I don't know, alleviating some of that burden and the financial limitations that are on there and bring in more dollars to fund more programs?
Yeah, it was super interesting when we were having these discussions. We were premising our discussions on prioritization and, what was timely access, what was medically necessary. We based all of those discussions on the premise that there's a fixed budget that we're working within. And several of the people with lived experience pointed out to us that that's a false argument, because there would be ways that we could increase funding into our healthcare system if that's what we chose to prioritize in Canada. In our evidence review at the CMA, and maybe we'll have to come back and have another discussion after the report gets released at the end of June, but really understanding what are the other options out there and what's the evidence for and against implementing additional systems. There are already people in Canada who have third-party insurance. They get their medications covered, their dental care covered, their glasses, prescriptions, and even hearing aids covered. And certainly we need to have a hard look at, is there a role for increasing public support for some of these programs, or do we continue on having this inequitable division in service delivery? It was there was an article just recently by a dentist in the media talking about what they had seen since the implementation of the dental program, and it really highlighted for me the inequity that Canadians face in some basic healthcare needs like dental care. And there's no question that dental care has a direct impact on our health. And that's something that we need to take to heart as we're doing a review of what are our best approaches in Canada moving forward. And then we need to keep sharing in real time what's working, what's not working, and having discussions with Canadians about what they feel are priorities. Because if Canadians know what their priorities are, share them with their governing bodies, then we'll see real improvement in our services.
Have the recent government proposals, I guess, been speaking to those priorities in terms of diabetic care and in terms of birth control access? Like, is that evidence-based, or what are your thoughts on that specific change?
So I think this was a first stab at expanding a program where the government had heard from citizens that these were priority areas. So reproductive health and access to diabetic care are their initial priorities. I do look forward to understanding what comes next and really having an understanding of how this program rolls out. But it's pretty clear that we've now come to the place, and I do think that our crisis in access is what's gotten us here. But it's pretty clear that better access to primary care, physicians, shorter wait times, easier navigation of this behemoth and complex healthcare system that we have are shared priorities across the country. And it was really interesting from my perspective that these engagement exercises, the town halls that we went through, really showed that all stakeholders, from healthcare providers to not-for-profit organizations to patients, they really value the Canadian healthcare system and resonating the importance that all representatives from all parts of the healthcare system be at the table and ensuring that equity deserving groups are welcomed and included in our discussions. But at the moment, we're just seeing this rising concern about the ongoing erosion of Canada's public health system, and obviously we need continued conversation that are evidence-based around public, private, and not-for-profit entities, driving essential services in Canada. We need to become more innovative, but those innovations need to be grounded in data, evidence, and a commitment to sharing in a transparent and accountable way what worked and what didn't work so that we can learn, adapt, and move forward.
When it came to those priorities at the town hall meetings, what was sort of the difference between the patient's perspective and the physician's side of things? I feel like I've always got my doctor blinders on, and it's easy to get stuck in that lens. What were the patients thinking differently from how we would be thinking?
So not everyone that attended the town halls was a patient. Many were people with lived experience, either personal or caregiver roles for families. But at the end of the day, we really agreed that in one way or another, whether you're currently a physician or other healthcare provider, at some point or another, you're going to be a patient too. So for us to come together across that common humanity, that at one point or another in our lives, all of us are going to need some form of healthcare now or in the future, either for ourselves or for our children or for our parents. We had this coming together of commonality, and the hopes and fears, as I said, for both those with lived experience and those that we're currently providing care, we're not that dissimilar. We're all the same. We're just fighting this fight from different angles.
Pretty aligned mutual interests for the most part.
Exactly.
What about from the government's perspective? What is their analysis of the risks and the benefits when it comes to expanding private versus public healthcare? Do they see that as a threat to control or autonomy, or how are they actually considering this debate?
So I think our governing bodies actually suffer from the same challenges that we suffer from, and that is a lack of clear, concise, and comparable data across jurisdictions in Canada. So we're hoping that the information that we've gathered from what we've heard from people with lived experience and providers through these engagement processes, alongside the deeper dive into the evidence, is going to be able to provide some insights, not just for Canadians and those providing care, but actually provide some framework for discussions and things that the governing bodies can look to and say, this looks like this is the way that we're going to proceed, and this is the evidence for us proceeding in that way. I think as long as we're clear and transparent with Canadians about how we are approaching healthcare in Canada, the support's going to be there. What we face now, where we're not really sure where did our money go, what services are available, how come I can get that in Alberta, I can't get that in BC. This inconsistency across the country is really driving dissatisfaction in Canadians. So hopefully this evidence work that we're doing at the CMA is going to help to inform governing bodies and Canadians alike as to what we need to do to improve the delivery of services and options for Canadians.
When it comes back to the data, because it seems to be, we always want to make those evidence-based decisions. And out of all the data that we do have, the one statistically standout piece is that Quebec has the most physicians that are either partly into the public system or fully removed from the public system. What's been sort of the accessibility and the comprehensiveness and the lack of barriers to patients trying to access care in that province? I don't know if there's any insights that have come from the data that we do have.
Yeah, so we did actually have a conversation in Montreal. We did one of our engagement sessions in Montreal, and it was fascinating to me because there are many more family physicians in particular who have opted out of the public system there. I thought I would hear more of a consistent call for more privatization, and in fact, that's not what I heard. What I heard was that the main driving forces of access to care and quality care were identical to other parts of Canada. Many of the physicians I spoke to in Quebec were opting out because they felt they couldn't deliver the quality services the way they felt they needed to be delivered inside of the public system as it existed at that time. So not necessarily comparable across the country, but really being able to collect data about why did physicians opt out of the public service in areas where they've opted out, and what would it take to actually provide the services that they saw as lacking in order to recoup them into a publicly delivered system. Data underlines all of these things, and we're not great at collecting health data in the first place. We're even worse at collecting data about who's doing what, where, when, and how around our healthcare services.
Well, what kind of data would change minds? What would we actually need to look at?
So a really great example, what would help us is when we look at delivering care at a community level. And having a conversation with communities around what they actually see needing. Back in British Columbia, when we were doing our early primary care network founding research and sort of getting things off the ground, that was probably 8 years ago, talking to local communities of providers and people with lived experience about what they need in their community. How many physicians do you need providing what kind of services? How many nurses do you need? How many social workers do you need? How many pharmacists do you need able to provide comprehensive reviews of medications and advice around chronic diseases? Having an understanding of what services are actually needed and then working out who's going to provide those services is foundational. But at the moment, if I pointed any given community in Canada, they wouldn't be able to answer that question in a robust way because they don't really understand what they have available to them right now. And secondly, we don't really have a good understanding at a population need what services we have the ability to deliver. We compare now often, our healthcare system where it's what Dr. Alika Lafontaine called a find your own adventure, choose your own adventure way of approach to our publicly delivered school system, where you would never expect a parent to move into a new community and then have to scramble to figure out, could their child go to school or would there be a teacher available to them? So we know there's other professions we can look to understand how we gather what we need and how do we deliver those services in the most efficient and appropriate way. We're just simply not collecting that information at the moment.
And then to facilitate the capture of that data, how do you even define medically necessary procedures and visits and access? If we're looking at, just who's utilizing what, I feel like it's very difficult to use that as the marker for what was needed. I feel like just because it was free and accessible, it got used even if the need wasn't there. How do you actually capture such sort of abstract information as pharmacists and medication reviews versus primary care access to a physician versus physiotherapy? How do you even go about kind of untangling that mess?
Well, I think at the beginning, we need to have a robust understanding of how many people are living in the community with what kinds of underlying conditions, chronic illnesses, how many births, how many children are born into that community every year, impacts, of course, public health services like vaccinations and wellness checks. There's so much from a population health point of view that we can collect from community. What we don't have great data on is what type of service provider is providing what services and in what setting. We're very focused on saying we have this many family physicians in Canada, we have this many surgeons in Canada, we have this many of whatever other subspecialty we have. We don't have granular data on what it is they're actually doing. And certainly in the specialty of family medicine, we know that counting a family doctor as a family doctor is not an accurate way to reflect what services are available. Many are working in emergency only, or working in specialized areas of care like long-term care, palliative care, maternity care. we need to have an understanding of what services are actually, are actually being provided by who, so we can start to understand that mismatch between the population health needs and the providers that we have working in any given jurisdiction.
Well, that's part of the mismatch too of just the accessibility of being a family physician. I mean, I have numerous encounters with patients regularly where they come to me for something and I wind up referring them to an allied health practitioner. I feel, again, that mile wide but an inch deep breadth of knowledge that a general practitioner has to have. I'm like, I am definitely not the person you need to be speaking to right now. You need a nutritionist, or you need a physiotherapist, or you need you name it, right? And so that's part of the challenge, is that people wind up coming to the GP as sort of the focal point and financially the most accessible for them, even though it might not be the best or especially the most efficient option in terms of how the healthcare system actually works.
No, exactly. I keep coming back to it, but I saw the Sherwood Family Health Team in Charlottetown in PEI last year at work, and I was so impressed with how they were able to incorporate social worker, physiotherapist, pharmacists, nurses, nurse practitioners, licensed practical nurses, all together to really try and highlight what services could be available within their team. So I agree with you. We have overlapping and intersecting scopes of practice between primary care services, specialty services, and other health providers in our system that we could leverage if we were actually all working as part of a team. But for the moment, because the family doctors and nurse practitioners tend to be in the emergency room actually as well now, tend to be that kind of input or pinnacle from which all other services flow, it's very inefficient. So building towards that team-based primary care home where you may have a musculoskeletal injury and get seen by a physiotherapist first. You may have a mental health condition that gets seen first by a social worker or by a psychologist. You may well have a medication review or chronic disease management done by the pharmacist. That is part of your regular care team in that ongoing and longitudinal way. So I think all of these things are possible, and all of these innovations are in pockets across the country. We can learn and shamelessly steal.
Is there a country that has the broadest access to those various allied healthcare practitioners? Just the most comprehensive universal coverage? And then I guess, do you know how they're doing in terms of their metrics and KPIs as to their health?
Yeah. So again, these are things that we're hoping to capture in our evidence brief to have a look at what our potential could be across other jurisdictions. As I've said, no one jurisdiction in the world has this completely right, and I think that the lack of sharing and tracking of health data isn't unique to Canada. This is a global challenge.
And then in the long term, what does the Canadian Medical Association see as its role in helping to guide or define the boundary between that private and public partnership? We're starting with data gathering. Where does it go from there?
The CMA is really doing this deeper dive into our current system of care to try and understand that balance and interplay between public and private healthcare. And as we finish this evidence brief and share that openly with Canadians and policymakers across the country, we hope to have some open and honest dialogues to address those questions and uh, the truths about our current system and the advancing creep of large corporations into our healthcare system in Canada. And I think our role is really going to be to share the evidence, to continue to have the conversations, to be that convener, and bring together people with lived experience, physicians, other healthcare providers, and policymakers, to say this is what we're going to do in Canada, and then we're going to learn from this. We're going to try this. If this doesn't work, then we're going to try something else. And those of us that work in primary care know that's often how we work. We work in the gray. We try something on that we think is the right fit, and if it's not the right choice, then we learn from that and move forward. but really highlighting, in a transparent and accountable way, what we're investing in and what we can reasonably expect from our publicly funded healthcare system in return is paramount. Really clarifying for Canadians what is publicly provided and where private care would be expected to have a role. This is a powerful place where the CMA as a thought leader and convener will have a role moving forward. Honestly, Jordan, under all of this, I remain hopeful, and I'm hopeful because I think for the first time in a long time, we're in a position where we can comfortably have these really uncomfortable discussions. And I do look forward to listening and learning with Canadians as we continue these dialogues.
What kind of time frame should we anticipate? If there are any changes coming up, are we looking at years, decades? What could we reasonably expect? Again, we continually hear about the crumbling of the healthcare system and we've hit rock bottom. Is this actually the rock bottom where things start to change and people are more open to trying some different or perhaps more radical ideas? Or do you think there's still a lot more potential decay and degradation that we have to endure before things actually meaningfully start to change or at least attempt new strategies?
I think most people in Canada now are alive to the challenges that the healthcare system is facing because they're alive and now asking questions, and in many cases asking the right questions of those that are able to change policy and guide systemic changes to how we collect data and how we deliver services across Canada. I think we're in a good place right now to see change. Change can be slow in the beginning, and then it will gradually pick up. And I can't give you an exact timeline for when I expect things to suddenly be where everyone will be happy with everything in our healthcare system, because I think as I look across the globe, no one jurisdiction has it completely right at the moment. But if we can move the needle closer to Canadians having access to care when they need it in a timely way that actually addresses the critical illnesses, chronic illnesses, and other things that we can decide are medically necessary in our public system, share back with Canadians in that accountable and transparent way, then we will see ongoing iterative change. But I don't think we're ever going to be done with this process, because new tech, new illnesses, new processes, new research, new evidence, all of this will continue to evolve as we move forward. What we hope to establish by having these discussions is understanding how the system works now, what we want the system to look like in the future, and then being really clear on what steps we expect to take to get there. And that shouldn't be married to a given timeline.
Hopefully sooner than later, though, in the positive direction.
And I think with the recent investments that we've seen and the bilateral agreements that have come out, coming together behind common identifiable goals, primary care being at the top of that, of course, improved wait times in emergencies and surgical times, diagnostics, all of those key priorities that we've set should help to establish the goalposts. Or perhaps that's not the right term. Perhaps they're more mile markers as we move along the path towards improving healthcare for Canadians.
What about trends internationally? There's the other countries and sort of the state of the union where they're at currently. What's the trajectory or acceleration that, the broader ecosystem seems to be undertaking in terms of that public and private balance? Are they starting to push more one way or more the other way, even if they were more traditionally public or even more traditionally private?
Every jurisdiction for healthcare services in the world actually does have an existing balance between public and private care already, and they sit in various proportions, and depending on where you look. I'm going to come back and say again that we need to understand what that interface would look like in a Canadian context. to really understand what's what it is that we need, because we're quite unique in Canada with regards to our social systems, with our geography, with this mixture of urban and quite rural and remote communities that is unique in Canada versus many other OECD nations, and trying to sort out what feels like the right choice in Canada is something we can look at other jurisdictions, but we really can't be completely replicating other jurisdictions because we are unique.
It's got to be one of the biggest challenges is just how least dense of a country we are in terms of our geographic distribution of the population. That's got to make a huge impact on that access to care.
I think you're right, but if we're able to transparently share what Canadians can expect, if you live in a community of 100 people, it's not reasonable for you to expect to have a 24/7 staff emergency department with full surgical services and obstetrical services. But what services could we enhance, could we support through technology to deliver in your local community? Is it reasonable for wait times for certain procedures to be much shorter in an urban setting versus a rural setting, simply because people in urban settings are able to access cancellations and things along those lines? So we have to have those conversations. But if we're open and transparent and actually name what services you can expect living in a community of your size in this part of Canada, I think people will be able to have a place to start to say, this is what I can reasonably expect, and then demand those services from their governing bodies.
Are there any other initiatives, not related to the public-private debate that you're the most excited for coming up in the following years?
I am very excited about the work underway with interoperability of data in Canada. I think this is a major burden with regards to healthcare delivery, and certainly streamlining access to data and improving how we handle data. Implementation of AI to actually help us with that is it's really exciting work coming down the line, and I hope to see more open sharing of healthcare information so we can better understand the disease processes at play in our community, and I hope to see better sharing of granular data on what healthcare providers are doing so that we can better plan for the long term of what we're going to need in the way of additional trained individuals.
I think that data, and then again, just the new computers and technology to make the most of that data and to upgrade our healthcare system, I think it's going to be a game changer going forward.
It will be, but at its source, at the core, we need to maintain that human-to-human connection that we know results in healing, even if we don't do a test, even if we don't do a medication. That connection from a human caregiver to a human in need of healthcare can't be replaced.
And then I guess before we wrap up here, I ask the same question to everybody. What is your personal secret to wellness? How do you actually keep yourself going and feeling good?
I have so many positive people in my life. I have a very supportive family and 2 adult children now that I cannot say enough good things about, and that energizes me. But on top of all of that is my extended family, and the patients that I see, the people that I interact with in the community, that ask for help, or I'm able to provide help. It really does fill my cup and keep me moving.
Amazing. Awesome. Well, unless you have anything else to add, thank you so much for taking the time to chat today. Really appreciate it. There's some great insights came out of the conversation.
Oh, I hope I wasn't too rambly, but I think we got all the information in there. So great to chat with you, and I look forward to chatting you perhaps again after our evidence report drops.